Imagine walking into a clinic because you're exhausted, foggy, maybe even worried about your heart. The doctor suspects sleep apnea. You're sent to a lab, hooked up to wires, and told to sleep while they count the times your breathing pauses. The next day you're told, you stop breathing X times per hour, therefore you need a CPAP machine. You strap on the mask, night after night, with the promise that this machine will solve your exhaustion, your brain fog, your risks of heart disease. But what if the promise is incomplete? What if the numbers that justify the therapy are only part of the story, and sometimes not the most important part? The entire medical system around sleep apnea is built on one number, the Apnea-Hypopnea Index, or AHI. That's how many times you stop or reduce breathing in an hour. Above a certain threshold, you're sick. Below it, you're fine. And CPAP, the machine that blows air into your airway to prevent those events, is the automatic treatment. The problem is not that CPAP doesn't work. It can, and for many patients, it is life-changing. The problem is that AHI has been elevated to the position of sole judge and jury. Everything depends on it: diagnosis, insurance approval, prescription. Meanwhile, the things that actually matter to people, whether they feel rested, whether their blood pressure improves, whether their thinking clears, are often not formally tested at all. This creates a strange mismatch. Doctors declare victory because the machine has lowered the AHI. Patients, on the other hand, sometimes wake up panicked, feeling suffocated, and drag themselves through another foggy day. When they tell their doctor, the answer is, the machine is working. You must be better. So science has started to catch up with this contradiction. Large trials have shown that lowering the Apnea-Hypopnea Index, or AHI, doesn't necessarily prevent heart attacks or strokes. Meta-analyses reveal that many folks using CPAP see little to no change in their daytime fatigue, and still the prescription continues just because the AHI improved. This actually tells us something fundamental. Apnea events and poor sleep may not be a simple cause and effect chain. They might instead be two symptoms of a deeper driver, like metabolic dysfunction, autonomic imbalance, or ventilatory instability. In other words, apnea is not always the villain. It may just be a messenger. If we silence the messenger without addressing the deeper problem, patients won't feel better. Sometimes they even feel worse. Now, how did we get here? The answer is incentives. AHI is easy to measure. It produces a clean number that looks scientific, reproducible, and billable. Insurance systems love it because they can define thresholds for coverage. Doctors lean on it because it feels objective, and companies that make CPAP machines benefit when more people qualify for them. But in this neat little system, there's just no room for the broader range of outcomes that truly matter to human beings. Fatigue, cognition, blood pressure, mood, cardiovascular risk markers, these are either ignored or left to subjective patient impressions. If you happen to feel better after starting CPAP, everyone's satisfied, but if you don't, you're told to keep trying, or worse, that it's somehow your fault for not complying. So, the real issue isn't CPAP itself, but rather the narrowness of the testing process that leads to its prescription. Now imagine if we could expand the evaluation. Before anyone is put on a lifelong machine, we would test not only AHI but also daytime sleepiness on validated scales, cognitive function on simple attention tests, blood pressure patterns during the night, and autonomic balance with heart rate variability. We would ask, does this person's type of apnea actually come from airway collapse or from unstable breathing control? And crucially, after a short trial, we wouldn't just look at whether the AHI improved. We'd retest those same broader outcomes. Did the patient's fatigue lift? Did their sleep architecture stabilize? Did their cardiovascular markers improve? If not, then the machine is not the right tool for them, no matter how pretty the apnea graph looks. The vision I'm describing is simple but radical. Put human outcomes back at the center. Machines should serve people, not numbers. That means broadening our tests both before and after CPAP is prescribed. It means recognizing that apnea events are one piece of the puzzle, not the whole story. And it means freeing patients from a system where compliance to a device is valued more than the restoration of their health. CPAP is not a villain. For some, it is a lifesaver, but for too many, it is a prescription handed out on the basis of a single metric, without regard for whether it actually helps the patient in ways that matter. If we want to live in a world where medicine is guided by outcomes instead of incentives, where science listens to people as much as it listens to machines, then we must demand more than an AHI score. The future of sleep medicine should not be a mask you strap on every night in hope. It should be a system that sees you, measures you as a whole person, and prescribes only what genuinely makes you well.